and whether you have access to respiratory specimens. So if you can maybe indicate for us where you work, whether you have access to chest X-ray, and whether you can do respiratory specimens at a facility or a facility close to you. I'm going to give a few seconds for everybody to vote, and then you can all see the answers for this at the end of the webinar. All right, I'm going to move along, and I'm going to ask Karen to start sharing with us what we can expect in the new TB guideline. Thank you, Karen, and yes, we're excited to hear what's coming.
Thank you very much, Helena. I have a bit of an echo though.
It's much better.
Okay, is it better? Great. Let me just remove these. Okay, great. Good evening, everybody, and thank you very much for the opportunity to start this webinar. And I think it's really nice to give the introduction to three great talks that's coming. And I just want to sketch a little bit of context and background to why do we need new guidelines for children and adolescents with TB in South Africa. Just to give you a brief overview, a snapshot globally, what is happening. So in 2022, we estimated around about 1.25 million children developed TB, and we had close to 215,000 deaths, TB deaths from 0 to 14. And at the bottom graph, you can look at the trends in case detection globally, and we see that dip where in 2020 and 2021, where there was an impact of COVID-19, but with case notification rates increasing again in 2022, which is encouraging. If we look at the South African data, we estimated about 27,000 children had TB in South Africa in 2022. We only had 16,500 case notifications, which gave us a case detection or treatment coverage gap, a case detection rate of 61%, or a treatment coverage gap of 39%, meaning that roughly 40% of our kids that we think have TB were not diagnosed and started on treatment and notified. And if you look at the top where we look at all TB cases, our case detection rate overall looks much better, 77%. So we're not doing as well in kids as we've been doing in overall in adults, and we need to do a bit more. If we look at the UN high-level meeting targets that was set for TB, specifically the indicators for children, which was case notifications in children or pediatric TB notifications, and you can see the gray dots are the targets that were set previously, and we also had experienced that dip due to COVID in our notifications. But in 2022, we nearly reached the target. But we have very ambitious targets set for the following 4 or 5 years that's coming. So we're really going to have to up our game to make sure that we find these children and really reduce the case detection gap. We look at TB prevention in children under 5 specifically. This graph is looking at contacts under 5. And as you can see there, we've really not done as well as in terms of case detection. So we only had about 17,000 contacts younger than 5 that was reported, where our target was just over 50,000. So that's also an area we can really work towards doing better. So why do we need new South African guidelines? And the picture there on the right is the guidelines, the previous guidelines we had, which is in 2013. And I think the reality is that there's been lots of research and a lot going on in terms of pediatric TB, really work that is building on people like Prof. Scarf and Prof. Hesseling and Prof. Gee and Bayer, and all of them who've done really, and Prof. Donald, who's done amazing work in pediatric TB and advocate really for pediatric TB services. And that gave more money and more research. So that gave us better data, right? So in 2021, the WHO convened a guideline development group, and they've set out 8 PICO questions around diagnosis, treatment, and implementation, and commissioned evidence synthesis reviews for these questions. And this informed the new guidelines that, well, they're not new anymore, but they updated the WHO guidelines in April of 2022 and released them, March 2022, with an operational handbook to guide countries in terms of implementation and how to implement these new guidelines. So in terms of diagnosis, where we have new research and new guidance, we're really recommending for the use of expert or ultra or any NOD-based testing, including stools and other specimens in children. And I'm just going to briefly touch on these because all the other speakers will go into more detail. But there was new evidence on bacteriological testing in different specimens. There was evidence on the use of treatment decision algorithms in children, specifically under the age of 10, and then also how to determine disease severity, which is important for the use of the new 4-month treatment regimen for non-severe TB. And I think the important thing that Juanita will also cover is that because of the poor bacillary nature of childhood TB, it remains a clinical diagnosis, and we really have this puzzle pieces that we have to put together to make the diagnosis. So from the WHO guidelines, I'm literally going to just highlight 4 of the new guidelines, which was informing our guidance. But it was the use, so they recommended the use of ultra on pediatric specimens, and they've included stool and nasopharyngeal aspirates as additional specimens that could be used for diagnosis in children or confirmation in children. Then they also had a recommendation in terms of the use of integrated treatment decision algorithms to diagnose pulmonary TB. And I think this is quite exciting because the treatment decision algorithms that they released in the operational handbook was from a synthesis from more than 4,500 children, or data from more than 4,500 children. But this is an interim recommendation, and they're also looking for better data to validate these algorithms, because a lot of the studies were from hospital-based studies where the children are obviously quite sick. So there's ongoing research at the moment in terms of validating how well these algorithms are performing, specifically at primary healthcare in children that are not so sick. So I think it's exciting to know that we are changing, and we have to be able to also adapt rapidly as new evidence becomes available, and make sure that we are on par with what is happening and what we know is best practice. And then I'm hoping that all of you have heard about the SHINE trial, which was published in the NEJM, and that was really a seminal trial, and South Africa was one of the sites that contributed data, but they really showed that for children with non-severe TB, children and adolescents actually with non-severe TB, a 4-month treatment regimen was non-inferior to a 6-month treatment regimen, which is really exciting. So in terms of the process, so those are the back matter in terms of informing the new guidelines. So why did we need them? There's new evidence, right? But then how do we go about incorporating them into local guidance? And I think the exciting first thing was the establishment of a national child, adolescent, and maternal TB working group, which is housed under the TB think tank. And the aim of this group was really to harmonize efforts to measure and improve TB care, not only to children and adolescents, but also pregnant women along the continuum of care. And as you can see, there's a broad representative of people, and it's really an open group. If anybody is still willing or keen to be included, they're welcome to contact me afterwards. So the group was established in October 22. Currently, we have 43 members, and we represent 6 provinces. We really have clinicians from tertiary, secondary, straight through to primary healthcare level. We've got rural representation, and then also lots of different committee and bodies that's represented through the members. And this group was to really help NDRH to develop the new guidance for children and adolescents. And it was an 18-month process. And I think everybody who has done any guideline development would tell you that that is how long it takes. I'm still appalled that it took us so long, but it really was an amazing process with wide consultation and incorporated multiple meetings, going back and forth, getting input from provincial TB managers, other program managers. We also did a survey a feasibility survey with healthcare workers, where we got input from about 162 healthcare workers in South Africa, from where we also incorporated some comments. So the final document was shared with the National Department of Health in March, and we're currently busy navigating all the regulatory approvals. So what you are seeing today is not hot off the press, because it's not off the press yet, but we're very happy to share with you what is coming. And yeah, it's very exciting. So as I said, this was really based on the WHO PICO questions and their evidence synthesis that formed the basis of the new guidelines. We've also looked at the Union Desk Guide. Helena will tell you more about the Diagnostic Chest X-ray Atlas. That's all free and available resources. And then we had to adapt all of these to the local context and consider IMCI guidance, the EPI guidance, STG and EMLs, as well as the new drug-resistant guidelines and the TB preventive guidelines. So it's really an exhaustive document with lots of detail. We try to keep it very practical, but really address questions that people are struggling with. And next steps, we are nearly I've completed the graphic design process. So as soon as we have all our approvals that we're ready to go, we have some operational recommendations regarding BCG that is currently under review at NAGI. Our treatment recommendations are also currently under review at NIMLEC. The 2023, as many of you, EML, as many of you might know, already recommends treatment shortening, but within this guidance, we give really good advice on how to practically decide who would be eligible for treatment shortening and who not. Then there's other treatment changes that Prof. Scarf will also tell you more about a bit later. I think the biggest thing is going to make sure that we align with other guidelines like IMCI and EPI, and make sure that as those are updated, everything aligns. Yes, and then there's lots of support from National Department of Health to release this as soon as possible. We've already had 2 symposiums at the SATV conference in June. We're doing this webinar, and then we're also planning some Knowledge Hub trainings, and then there'll be lots of activities from NDOH once it's released to make sure the data is communicated, and yeah, and there's training for staff. And I think that was it for me. So obviously, thanks. This is I think this entire guideline has really been a collective effort from a lot of different people who all willingly provided their own time and expertise to really guide better treatment and care for children with TB in South Africa.
Thank you very much, Karen. I think if you have questions, please post them in the chat, and we're going to try and answer as many of them. And maybe if there's time at the end of the webinar, we can also address some of them. I'm going to though move on to the next presentation, and it's going to be me. And I just thought it's a good idea to talk about just the steps in the tuberculosis treatment decision making. And I want to remind you that children can present to the health system in different ways. One of the things that we really need to encourage is the active case finding, where we are actually looking for children who present with illness that we are looking for children who are in contact with adults with TB, and these children can be ill or they can be well. And then we also have passive case finding, where children are coming to the clinic and they either have symptoms or if they don't have symptoms, we contact trace them through adult contacts, and we can ask if there's exposure at each visit. And we want in the guidelines to have strategies for all of this. I want to also remind you that part of the decision making of children when we are talking about tuberculosis is not only about treatment, but also whether children need prevention. And we know that after exposure, children are at high risk of becoming infected and develop disease, and that is an age-related risk. And, you know, traditionally, we like to focus on those children less than 5, and particularly the ones that are youngest, less than 1.5 or so. But adolescents are also at high risk of developing disease after infection. And we really have a short time to find those children. TB cases are often diagnosed within the first 90 days after exposure. So this case finding component is a very important part of our treatment thinking and our treatment decision-making process. And there's actually a very narrow line between infection and non-severe disease. And I think sometimes it can actually be quite difficult to know whether somebody has non-severe disease and may need very limited treatment, or whether the patient actually has a latent infection that we are treating. And so there can be challenging clinical cases, but the idea that we really have is that we need to examine the patient and use all of the clinical data that we have available to decide if we have disease or if we need to treat infection. So as I mentioned, and as Karen also mentioned, we need to use a combination of strategies that starts with the history and the clinical assessment, look at the availability of imaging and diagnostic testing, and always includes knowledge about the HIV status. And at the end of this process, we need to decide if somebody has infection, which we would treat with TPT, or disease, which needs full treatment. So I'm going to go with a little case again. So a 4-year-old boy who has a TB contact, he has no symptoms, and you manage to also do a respiratory specimen, and on the specimen you see it's negative, and you think this chest X-ray looks like exposure. What do you think is the most appropriate therapy for this patient? Okay, so here we go. Is it INH preventative therapy for 6 months? Is it INH and rifampicin for 3 months? Is it rifampicin for 4 months? Don't treat infection, treat disease, or you need more data? So I think if we think it's TB infection, not disease, then obviously we want to provide TPT. And we know that the new TPT guideline actually in children that are not living with HIV is highlighting the fact that we can actually use 3 months of rifampicin with INH. But it's very important that we always ask ourselves, who is the contact of the child? And this is actually a real patient. And you can see here, that this patient has a contact with a rifampicin resistant. Sorry, I'm out of sync with the poll. I'm sorry, Marty. Let's give people, let's leave that there. But what I wanted to show you here is that this child has contact with the adult source case who is rifampicin INH resistant. So it's very important whenever we're looking at infection or disease, whether we want to provide TPT or treatment, that we always consider who the adult contact is, because our actions will depend on the adult contact. So in this case, we would need to think what would be the most appropriate preventative therapy for this patient, which would be in actual fact rifampicin for 4 months. We know that the majority of pediatric tuberculosis transmission is due to household contact. But in actual fact, we also know that in South Africa, where there's a high force of infection, a lot of those exposures are actually also happening outside of the home. And the risk of becoming infected and becoming disease is really dependent on the sputum smear or how contagious the contact is, as well as the age of the child and their HIV status. And I want to highlight again how to treat TB infection. These guidelines were made available last year. And there's also now new data on the use of fluoroquinolones to prevent drug-resistant tuberculosis. And these are not actually included in this TPT guideline. So if you have a patient with rifampicin-resistant tuberculosis, it's worth considering whether you should want to provide a fluoroquinolone to prevent tuberculosis in those children. And if you don't have experience in that, to consider contacting an expert to decide if this should be considered. If we want to treat disease, we want to really know which sites are affected and if the patient has severe disease. So sites, we want to know about pulmonary tuberculosis, for instance. We want to know about the age of the patient, what is the severity of the clinical presentation, and the chest radiograph. And though it's rarely done, if a sputum smear was done, you want to know that result. From the extrapulmonary tuberculosis, we want to know which organ is involved, and the only extrapulmonary tuberculosis that would be considered non-severe is actually neck nodes. And when we are now talking about treatment shortening and severity of disease, this is very, very important part to remember when we are talking about treatment shortening and assessment of disease severity. And we also want to know the HIV status of the child, because if the child is on antiretroviral therapy and we want to use TPT, we need to adjust according to the antiretrovirals that the patient is using. And if the patient is not on antiretroviral therapy yet, we also want to start antiretroviral therapy. And obviously, if the child is on treatment, you want to know if they have suppression. In other words, we really want to know what is the viral load of that child. So this is just sort of, in a nutshell, the steps of decision-making. Really important to decide if you're treating infection or disease. Really important to know what is the susceptibility pattern of the contact. And then also really important to decide which organs are involved and what is the disease severity, and always to know the HIV status. We're now going to ask Yonetta to share with us the important new part of the TB guideline, which specifically talks about how to diagnose TB in children. Thank you, Yonetta.
There we go, I was muted. Thanks so much. I'm Juanita Louise, and I'll be just going through the section of the new guidelines, and I'll be looking at screening, assessing, and diagnosing, and some of the updates. And just to reflect again on what Helena has already mentioned, that when we look at the diagnosis of TB, it's useful to use the puzzle as an image to keep in mind, because the more pieces of the puzzle you have, the better the idea, or the better the picture you'll get for the child. And if there are any puzzle pieces missing, you might miss out on the full picture. So we try and get as many as possible. And so our basis, history and clinical examination, and obviously history includes symptoms, but it also includes TB exposure, either a known exposure or a symptomatic contact that needs to be investigated. Clinical examination should always include plotting growth. And we can't, this is a puzzle piece, we can't leave out HIV status. If the child's last test is negative or unknown, we need to be testing the children that are investigated for TB, for HIV. And chest x-ray and diagnostic testing as much as possible, please to perform. It makes a big difference with making the diagnosis, and I'll go further into the details. But a very important point to make is that TB in our setting should be considered as part of the differential diagnosis in any ill child, especially if there's no alternative cause for symptoms found, or if there's a history of TB exposure, and given the fact that TB can present with a wide variety of clinical presentations. So next, I'll just look at triage, and the question is, does the child need to be admitted? Are there danger signs needing urgent attention? I won't go through all of this, it will be in the guideline, but it is important to look for these things. And then this is the exciting new bit that I will be presenting to you also. This is the TB treatment decision algorithm that has been developed for this guideline. So to start off, we ask ourselves, why do we need treatment decision algorithms? And as Karen and Prof. Robbie have mentioned, that there's a large burden of undiagnosed TB in children, especially in those under 5 years. Some mathematical models estimate more than 65% of underdiagnosis. So then we ask ourselves, what are the barriers to making the diagnosis in our country? So some of them could be that sample collection there may be some reluctance with sample collection in young children, lack of access to certain equipment, perhaps lack of access to chest X-ray, but also maybe a lack of confidence in diagnosing TB and initiating TB treatment because it can be tricky at times. And so the concept of the treatment decision algorithms is that if there is sufficient clinical and or radiological evidence for TB, we may not need to delay TB treatment waiting for results. We can perform the respiratory specimen testing, we can do the chest X-ray and look at the results and make a decision quickly. And we, especially in the high-risk children, and the algorithm defines these as children that are under the age of 2 years, children living with HIV, and those that are severely malnourished. So as been mentioned already, these algorithms are based on the WHO integrated treatment decision algorithms that were published in 2022 in the operational handbook. It was based on a meta-analysis that used logistic regression modeling to create this little box that you see on the bottom left over here. And it's a symptom and sign plus minus chest X-ray scoring system, and they aimed for a sensitivity of about 85%, which they achieved. But they accepted a specificity of 30 to 37%. And this box, which is algorithm B, just including the signs and symptoms, is the one we've included. Why am I telling you all of this? Because when you look at the algorithm, or when you look at anything really in medicine, it's useful to know what the diagnostic accuracy is. And so we know here that this is quite a sensitive symptom box, but not so specific. So amongst the group of children that have TB, it's going to pick up a lot of the cases, which is great. But amongst the group of children that don't have TB, but have some signs and symptoms, it may overdiagnose. And you can keep that in mind when you look through the algorithm itself. But the point of having these is that this sort of tool helps you to ask the right questions and do the right investigations timeously and have some guidance to get to an answer for whether to treat or give prevention or follow up. Okay, so I'm going to go from the top down, and obviously we start with screening. My main point here is that screening for TB symptoms and TB exposure must happen in all children at every healthcare encounter as much as possible. And we would have a special focus on the high-risk children that are immune compromised or immune immature that I've mentioned before. Also, children with TB in the past 2 years are at risk for developing it again. And then again, just to reference those treatment of TB infection guidelines from last year, there's a great definition of what a TB exposure is. And this is a really important thing to remember. So a TB exposure is exposure to an adult or an adolescent with pulmonary TB in the past 12 months. So it's not enough just to ask the caregiver, do you know someone with TB that the child's been exposed to? But can you think of anyone in the past 12 months that the child may have been exposed to? For a night or longer, or frequent extended daytime periods. So it doesn't necessarily have to just be in the household, as mentioned, but it can be in the creche and the school. And a lot of our participants in our studies and in our experience have been exposed with the neighbors. And those are important questions to ask. Another important question to ask is, are there any contacts that have TB symptoms that need to be screened? And we should go out and make an effort to screen them. And then on top of that, it's not enough just to say plus TB contact in the notes and move on, but to take the name and surname of the patient that they're exposed to and use LabTrack when it's working to look for drug susceptibility. And this will really guide your child's treatment regimen. Okay, so we've done screening. Now we're at history and examination, and you all know the typical symptoms that children present with TB symptoms. So it's cough, loss of appetite, fatigue or reduced playfulness, failure to thrive or weight loss, fever, perhaps for more than 2 weeks, or drenching night sweats. And then just to highlight a few things, the cough, as you all know, can be persistent. If you leave a child for long enough with TB, they will have an unremitting cough, especially the coughs that don't respond to antibiotics. But also there's good evidence to show that children with pulmonary TB can present as an acute pneumonia in hospital, especially those that are infants or immune compromised. So it's important to keep that in mind and not exclude those with a short duration of symptoms. Remember that a child with a wheeze or noisy breathing that doesn't respond to nebs can be due to lymph nodes compressing the airways. And I think all in all, I just want to really emphasize that TB symptoms can be vague and non-specific. So we really need to have a high index of suspicion, especially in our setting. And just to add that there are other presentations of TB, extrapulmonary presentations that I'll go through. Blood stain sputum is important, but it's more common in older children or adolescents rather. And I'll go into TBM just now as well. And Prof. Robbie mentioned, please, to give TPT to the children that are asymptomatic. We don't want to take them through the algorithm, realize that they're asymptomatic, and then leave them without prevention. It's really important that they go home with something at the end of this if there's a TB exposure. Okay, and then I'll just mention growth because it's one of the most important things when you're assessing a child. So your child may start off with insufficient weight gain, going to growth faltering before they start losing weight. And we really want to pick them up early where there's insufficient weight gain. So this is based on the WHO definition for failure to thrive. Insufficient weight gain is defined as a clear deviation from the previous growth trajectory. So it's just going off. And then growth faltering is where there's flattening of the growth curve or crossing of the percentiles in the last 3 months. But we've all had the Road to Health card that we open and see that it's completely blank and you're the first person putting a dot on the page. So in those cases, if you get a weight for age less than -2 or based on the WHO guidelines, a weight for height less than the -2, this can be defined as failure to thrive. And then we can go into the documented weight loss. But also remember, children that have any form of malnutrition that's not responding to nutritional intervention and deworming, and children living with HIV not responding to ARVs should also be considered for TB. Okay, and then to speak to the danger signs, I've mentioned this prior, but the next part of the box is also reminding us to look for signs and symptoms of TBM. And this is because TBM has quite a high mortality and morbidity, and we want to avoid that. And I think the main point to make here is that the symptoms and signs of TBM can be non-specific early on. So you can have the constitutional symptoms, a low-grade fever, cough, loss of weight, failure to thrive, decreased playfulness. But very importantly, one big red flag to notice is vomiting without diarrhea. Any child that's got a TB exposure and vomiting without diarrhea, we should have a very low threshold for performing an LP or referring for an LP. And then as time progresses, the older children present with headache and neck stiffness, and it's important to ask the caregiver about regression of milestones, which you may not notice without asking, or abnormal or changes in behavior and irritability, and then things may progress to worsening signs and symptoms as noted here. But of course, younger children and children living with HIV actually have a much higher risk for severe disease and sudden deterioration. So we really need to have a low threshold for investigating these children. And Prof. Scarf will also mention this, but a child with miliary TB on the chest X-ray must be treated as TBM if you have it. Okay, and then this is not. It can literally affect any organ in the body. But I just want to mention 2 other red flag signs. One is a child with back pain and another is a child with a limp. Please have a low threshold to investigate them for spinal TB, especially if there's an exposure. Okay, and then our last bit of history and clinical examination is to determine whether this child is high risk based on the definition. And so that's children under the age of 2 living with HIV or with SAM, severe acute malnutrition. If not, then you ask yourself if they're having persistent or non-remitting features typical of TB, and is this lasting for more than 2 weeks? And if yes to either of these, if they're high risk or they're not high risk, but they have persistent symptoms, they can go further down into the algorithm. But if they don't have persistent symptoms and you're still concerned, you actually have the option to follow up this child in 1 to 2 weeks if the diagnosis is uncertain and there's no danger signs. But this is really depending on the likelihood that your child can return, and especially if they can return earlier for any worsening symptoms or danger signs. So it's very different if you're in an urban setting compared to if you're in a mountain in the Transkei and your child has to travel quite far to get to you. But if you do have the luxury of a follow-up in 1 to 2 weeks, make an effort to treat the most likely non-TB condition. This could include antibiotics for cough and fever if you think that there could be a bacterial infection, nutritional rehabilitation for children that may have malnutrition, perhaps due to food insecurity, and then rehydration for AGE, etc. And when they come back, we need to then reassess completely, reassess the weight, plot them again, and reassess for persistence and improvement of symptoms. And that takes me to the next box. So now you've got a child that's either high risk with some symptoms or has got persistent symptoms, or you follow them up and it's persisting. And now you can perform a chest X-ray and take samples. And Prof. Scarf will go into this a bit further, but please try and do a chest X-ray as much as possible, because it will really help you to determine severity and treatment duration. And remember to do a lateral chest X-ray so that you are able to see the lymph nodes a bit clearer. And then I'll go into diagnostic samples. So the first question is, should I take respiratory samples? Yes, please. Please make every effort to collect a sample. It is possible to collect samples at all levels of care. And I'm saying this with our fantastic experience in this district, where we have a really enthusiastic TB team, and we've trained nurses in the districts, including the clinics in the rural areas and in the farms. We've got nurses performing induced sputum on mobile clinics in the farms, and it is possible to get useful results. And especially we want to try and get samples for the young children, those exposed to DRTB, or those with complicated or severe disease. And then I see that there's a few questions about, I'll speak about the diagnostic testing, but the respiratory sampling. So I've sort of ordered this in order of yield. So the induced sputum and the gastric washing have some of the best yields for sampling in children. The nasopharyngeal aspirate does not have as good a yield, and so you'd reserve that for where you can't perform the IS or the gastric washing. Obviously, if your child's intubated, you can take an endotracheal aspirate. A lot of people ask about stool. It is approved by the WHO as for TB NAT testing, not for culture. But we just need to remember that the stool has a relatively low yield, much lower than the other samples here. And so we tend to reserve this for children where you can't perform any of the other respiratory sampling methods. And then, of course, if there's extrapulmonary TB, make every effort to get fluid from wherever you can. If you've got fluid, you can test it for expert or other NATs. Okay, and I saw a question in the chat about Roche, so I'll just mention this briefly. So we're using the term TB NAT, which is nucleic acid amplification testing, which includes GeneXpert Ultra and other PCR testing methods. And you can get RIF resistance. Some of them give INH as well, which is great. The WHO has actually approved the use of GeneXpert Ultra and Roche TB PCR for children. And the NHLS, I think some of you would have noticed, has rolled this out in different parts of the country. There is less data for the other two in children as compared to Expert Ultra, but as time goes and we continue testing with these methods, more will come out. And so just to mention 2 important points about TB NAT. One is that it's a diagnostic test, so you can perform it at diagnosis, but it's not for treatment monitoring because it will detect dead or alive bacilli, unless you find ongoing symptoms or you have a concern for resistance, in which case it will give you a quick result about resistance. And the second very important point, both for TB NAT and for culture, is that a negative result does not rule out TB disease. And so you can perform your best respiratory specimen in a young child, and you may get a yield at best of 20 to 30%, and the other 70% of children will need a clinical diagnosis. And so it's really important to perform this because getting a result has a massive value for the child and for the diagnosis. But if it's negative, it doesn't mean that you've excluded TB. Should we do TB cultures? If possible, to get extra volume, you'd start with the NAT. If possible, to get extra volume, try and take a culture, especially if there's been a DRTB exposure. But remember to trace the results because they take a while to come out and we can sometimes forget to follow that up. And then should we be doing smears? In young children, probably not, because it's often negative. In older children, it may yield positive results and may suggest cavitatory severe disease. But another important point to note is that if your smear and culture is negative at base, okay, and then urinary lamb is another big question that many have. And just to clarify, urinary lamb is only for children and adolescents living with HIV admitted to hospital. And if you've got a symptomatic outpatient child that's living with HIV, you would perform the lamb only if the CD4% is less than 25% in those under 5, or if the CD4 count is less than 200 in those over 5 years in the past 6 months, or if they're either stage 3 or stage 4 defining illnesses. And an important caveat to note is that there is an issue with false positivity, a small issue with false positivity with urinary lamb, especially from bag specimens, given cross-reactivity with other urinary infections and nappy rashes. And so it does help if you can try and get a clean catch or use an in and out catheter. And also to mention, the Alere lamb has a specific protocol, and you need to actually wait 20 to 25 minutes for the results. So just be mindful of how to read these results and interpret them. A quick note on MANTU, the recommendation in this guideline is not to use MANTU unless you have a case where you've got a child with TB symptoms, but you have no known TB contact. And why is that? If the MANTU is positive and you already know that a TB contact is there, it's not actually telling you anything additional, and you're just pricking the child for nothing, really. But it is really useful if you have it available, if you've got TB symptoms and you want to be sure about an exposure. If it's positive, it indicates TB infection, but it doesn't confirm disease. So keep that in mind. But also, if it's negative, it doesn't exclude TB infection or disease. And that's because it requires a functional immune system to be positive. And more than 2 weeks post-exposure, and we have lots of reasons for having a non-functional immune system in our setting. And also, it depends entirely on how the procedure is done. And you know the cutoffs for the positive MANTU. Okay, so now you've done your investigations, you've done your history and exam, your investigations, and now we go on to interpretation. So obviously, if the chest X-ray is suggestive for TB, and obviously if you get a positive result on a diagnostic test, including LAM, you can now treat for TB. But what do you do if the X-ray is normal, or the testing is normal, negative, or you don't have any of these things available? Then you can ask yourself this question: is there a closer household TB contact for this child? And do I think that this child has TB? And there's a little 3 there next to positive TST, and I just want to highlight this. If you've got a child that presents with TB symptoms and it's persisting, and you really do think that this child might have TB, and then there's a TB contact, and you feel like you've got enough symptoms to diagnose TB, but you don't have access to X-ray and NAT, it is okay to make a diagnosis and treat for TB without waiting for a long time to get those things if it's not available. But just to also say that, if you're uncertain, and at this point you're seeing this child and you're like, I'm not really sure this child has managed to get through the algorithm, but I'm not really sure that even though they have a TB contact, that I really think they have TB, and the child is stable and the symptom duration is short, then you can give them the chance to follow up again in 1 to 2 weeks to reassess for symptoms. Or if you're unsure, there is this symptom scoring box that you can use that I mentioned before. And so here we would use the symptoms and plug them in, and they'd get a score. You can see the scores to the right, add them up. If it's more than or equal to 11, it's suggestive that the child has TB, and you can consider initiating treatments. But again, just to mention, this whole symptom scoring tool, the TB treatment decision algorithm, is primarily created for the primary healthcare level, where you may have limited access to chest X-ray and bacteriological testing, in which case you must just note that the TB treatment decision algorithm does not replace sound clinical judgment. And so if at any point it doesn't make sense, feel free to call for help or follow up the child if possible. Okay, so that's the algorithm. And the last point I want to make is don't do it alone. Help is always one call away. There's a lot of really useful resources. I'm sure we can make these numbers available for those that need them. And I just really want to encourage our colleagues in pediatrics and that are experienced in TB to try and connect with the TB district teams and create networks with the nurses at clinic level so that we can offer this level of support in all of the districts and provinces in our country. Thanks very much. We look forward to questions later.
Thank you very much, Juanita. I think we all really followed along nicely on how best to use the scoring algorithm. And we're now going to hand over to Professor Simon-Scarf on what is new in the guideline and how to use the guideline on an everyday basis.
Yes, thank you very much, Helena, and also for an excellent overview on the diagnosis, Juanita. So I'm just going to talk about what's new regarding the decision about shorter regimen for both drug-susceptible and drug-resistant tuberculosis. But mainly, I think for this guidelines, it's a shorter 4 months regimen in children with non-severe pulmonary tuberculosis, and also those only with peripheral lymph nodes or peripheral lymph nodes with non-severe pulmonary tuberculosis. I'm going to just touch on the ethambutol, why it's included now in the intensive phase of treatment, and the new dosing guidelines for both drug-susceptible and drug-resistant tuberculosis, and then also on tuberculosis meningitis and miliary tuberculosis. So we have referred to the updated Union Chest X-ray reading atlas, and I want to encourage you to read this little booklet. It's only about 100 pages with lots of pictures, so it's easy to read. A very nice bedtime story. It will help you to evaluate chest X-rays much better. And the important change in this guidance is that it now also helps you to decide on the severity of pulmonary tuberculosis by deciding is it non-severe or severe pulmonary disease. So please, I think it is in the chat, downloaded the link so you can read this atlas. So when deciding on severity of disease, we have two algorithms in the new guidance or the draft guidance. One is for decisions deciding on non-severe tuberculosis where you have a chest X-ray available, and the others that I will show just now is where you don't have a chest X-ray available. So the shorter 4 months regimen with ionized rifampicin, PZA, ethambutol for 2 months, and then 2 months of ionized rifampicin is restricted to children under the age of 16, but also children 3 months or more. So not for neonates, not for very young infants. It's for 3 months and up. When the guidelines come, you can read all the others. I want to just point out some other important aspects. It's only for children with a first episode of tuberculosis, so not for any child that had previous TB treatment, because they may have immunological reasons why they have TB for the second time, or they may have been mistreated. So only the first episode of TB. For children living with HIV, the viral load should be less than 1,000, and they should have been on, in the preceding 3 months, and they should have been on ARVs for more than 3 months by the time the diagnosis of tuberculosis is made. Regarding the chest X-rays, they are eligible if none of the following are present, and I'm going to show that on the next slide. But basically, there should be no complicated intrathoracic lymph nodes, so no compression of the airways, no collapse or hyperinflation of lobes or lungs. There should be no consolidation of more or equal to one lobe. So even if there are more than one area of consolidation, if it's less than one lobe, that will still go as non-severe tuberculosis. And the complicated pleural effusions, they will not be included in non-severe TB, but the simple pleural effusion will be part of non-severe TB. And then miliary TB and any chest X-ray with cavities is severe tuberculosis. So it's not non-severe. Very important also is the last box where it shows follow-up, so that after 1 month of treatment, all TB signs and symptoms should be improving. And at 4 months, when you decide to stop the treatment for non-severe TB, all the TB symptoms and signs should have resolved completely. So here again, you have some examples of what is not non-severe or severe tuberculosis. So in the first chest X-ray on your left, you'll see large lymph nodes with compression of airways, where the arrow shows. So that will be severe disease. In the middle chest X-ray, the whole of the left lung is involved, and you can't clearly see it, but the airway is also compressed. But the fact that there's one or more lobe involved with the consolidation makes it severe. And on the last X-ray, there's a cavity in the gone focus. The fact that it's just a gone focus doesn't matter. There's a cavity. If there's a cavity, it's severe tuberculosis. It's not non-severe tuberculosis. On these X-rays, you can see what a loculated pleural effusion looks like. It looks like a ball under the carpet. If you push a tennis ball under the carpet, it makes this kind of pattern. And that is what you can see on this slide. So a left complicated pleural or loculated pleural effusion, that is severe tuberculosis. And then miliary TB is always severe tuberculosis. So what does non-severe tuberculosis then look like? And Janita showed you the table from the chest X-ray atlas. And on the left, you'll see non-severe tuberculosis, and on the right, all the severe tuberculosis. So non-severe would be uncomplicated lymph node disease, as you can see on the top X-ray on your right. There's only a lymph node, there's no airway compression, there's no involvement of the lungs itself. And even if there was, it should be less than 1 lobe. So this will be uncomplicated lymph node disease, and will be diagnosed as non-severe tuberculosis. On your left top is a simple pleural effusion, which will be non-severe. At the bottom, you have 2 X-rays, an AP and a lateral. And although the right middle lobe is involved on the chest X-ray, it's only less than a lobe. It's not the full lobe that is involved, and there may be lymph nodes in the right hinder area. So that will also be uncomplicated or non-severe tuberculosis, which can be treated with 4 months treatment. So I have a case for you to decide. A 7-month-old infant who presents with a cough for 2 weeks, has flattening of weight for age on the growth chart, and fever at night or night sweats. The child received 5 days of antibiotics, but is not really improving. On further history, the infant was in the care of the aunt, who was recently diagnosed with rifampicin susceptible tuberculosis. So we will reckon that as drug susceptible TB. And the infant was then considered to have presumed pulmonary tuberculosis. And on clinical examination, she had a slight wheeze. She was breathing at a rate of 45 per minute. And there was no peripheral lymphadenopathy. And I'll show you the X-ray. And if you can have a look at the X-ray and decide whether you think the X-ray shows severe or non-severe tuberculosis, and you can vote. I'll give you a minute or 30 seconds.
Okay, so we've got almost like 250 people's votes. So I think I'm going to end the poll. Is that okay with you, Prof. Scott?
That's fine. That's fine.
Okay, good. We're going to end the poll, and I will share the results, and then maybe you can talk us through the answer.
Yeah. Okay. So on the next slide, if you look at the chest X-ray, and thankfully there's a AP unilateral, you can see that there are massive nodes in the hilar area, specifically and easily seen on the lateral chest X-ray, right hilar nodes. But the important part is that there are nodes subcarinal, which is actually causing compression of the left main bronchus. And although there's only less than one lobe involved, and there are hilar nodes, also paratracheal nodes on the right, the important decision here is because of the compression of the airways, it makes it complicated disease and therefore severe tuberculosis, not non-severe tuberculosis. So when you work in an area where you do not have chest X-rays available to you, we also need to make decisions. And although the SHINE trial was not done in this situation, we decided that even in this case, some children may be included in the shorter treatment of 4 months. But we have excluded now all the children between 8 and 16 years because the adolescents and older children more often have adult type disease. And if we don't have an X-ray, we cannot exclude cavities. So this will only be for children between the ages of 3 months and less than 8 years. All the others are the same except for children living with HIV. We have excluded them because we cannot without a chest X-ray, judge fairly what is going on in the chest of these children. But for the rest, it's the same as with the X-ray available. And just a reminder that if a specimen was sent for microbiology, microbiological testing, if it is AFB positive or smear positive, those children, all of those children will be excluded from the non-severe tuberculosis, because if you have, you need about 1,000 to 10,000 organisms per milliliter of sputum or respiratory sample to have a positive acid-fast bacilli. So that is definitely severe disease. And the follow-up is the same. Coming to the dosing charts, I put the full dosing chart here, and remember that this is for drug-susceptible tuberculosis and excluding patients with central nervous system or TBM tuberculosis and then miliary tuberculosis. And I'm just going to the next slide to show you the top of the slide, and you'll see here that the intensive phase of all of these patients are the same. So we have ionized rifampicin PZA, and there's a combination, fixed dose combination tablet, which should be available all over South Africa now, and in many countries, African countries. And we have included ethambutol now in all of the patients for the intensive phase. And I'll get back to that. Then coming to the continuation phase, we have 3 groups. One is the non-severe TB, where the continuation phase of ionized rifampicin will be 2 months. For the severe pulmonary tuberculosis and all extrapulmonary tuberculosis, excluding the peripheral lymphadenopathy, which is mainly in the neck, will be 4 months, and it can be extended to 7 months if it's severe or extensive disease. And then bone and joint disease is longer, up to 10 months of treatment for specifically spinal tuberculosis. So why ethambutol as a fourth drug in all children with on intensive phase treatment? So in the past, ethambutol should have been included in all children older than 8 years of age, and I've often seen that it wasn't, and it is actually an incorrect way of managing these older patients. And that is in all settings where the ionized resistance is more than 4%, and South Africa is definitely such a setting. It was also included in all first-line regimens for children with severe pulmonary tuberculosis, with all children with tuberculosis and HIV co-infection, as well as severe extrapulmonary tuberculosis, except in TBM and miliary TB. But now, because the SHINE trial was done in several countries, not only in South Africa, 70% of the children in the shorter regimen during the trial actually received ethambutol as a fourth drug in the intensive phase. So we cannot say whether the shorter regimen will work without ethambutol. It was not sufficient to exclude ethambutol in the intensive phase. So for that reason, we think that it is necessary to give ethambutol to all children on the shorter regimen as well. This makes practical implementation of for first-line TB treatment much easier, because you don't have to decide, should I give ethambutol or not? Everyone gets ethambutol. And hopefully, well, currently we only have the 400 milligram tablet available, but hopefully with this change, the Department of Health will also get ethambutol, the 100 milligram dispersible tablet, available to the children. Coming to TB meningitis, and that is includes also tuberculosis and all children with miliary tuberculosis. And why miliary tuberculosis is included, that is that miliary TB, patients with miliary tuberculosis have central nervous system involvement in 60 to 80%, and that has been shown in adult studies, and it has been shown in children and studies with children. The problem is the CSF can be completely normal, but when you do an MRI scan, not even a CT scan, but an MRI scan, you can see miliary tubercles throughout the brain, in the brain tissue in most of these patients. And therefore, all children with miliary TB should be treated as if they have TB meningitis. So the difference in the treatment is that we give 4 drugs for the full duration of treatment. That is 6 months, and in the cases of patients living with HIV, it will be up to 9 months. And those drugs are then ionized rifampicin, PZA, and ethionamide. And you will see in the table that we use a combination of ionized rifampicin plus separate PZA, because otherwise the PZA dose goes very high if you use a combination to get sufficient dosing of rifampicin and INH in the combination that we give. Just on TBM, when can we decide to discharge the patient? Because many of the patients in the Western Cape are treated in hospital, and there are very good reasons for that. And many of the provinces say are discharged, but one should be very clear on when you can actually discharge patients with tuberculosis meningitis, because this is a very severe disease. If you don't manage them correctly, they will come back in a much poorer clinical state with severe sequelae or death. And therefore, we need to decide very carefully when can we actually send these patients home. So the patients should have good tolerance of anti-TB drugs. They should be clinically stable. There should be a reliable caregiver who's going to give the medicine, who knows how to give it and will give it for this full duration of treatment. And they should understand very well that what the duration of treatment is. I think it's important that we have a named clinician that takes care of this patient, so that this patient can be followed up correctly. And whatever facility this patient is referred to, the medication should be available at that facility, and they should be able to detect missed appointments so that these patients can be recalled when they do not arrive back. And just this morning, we saw a patient that was diagnosed in a tertiary hospital, was sent home on treatment after 2 months, and after a month, the mother did not return and no one followed up. It's so important because this patient came back with a stage 3 tuberculosis meningitis, which was preventable. And that is what we wanted to prevent, was making the correct decisions. What's new in treating rifampicin or multi-drug resistant tuberculosis and disease in children in adolescents? So now we do have shorter all oral regimens for children with RRTB, mainly 9 months, but in non-severe RRTB, as in the case of drug-susceptible TB with non-severe disease, the same way of deciding on non-severe TB. These children may be treated for 6 months only, and only those with RIF mono, MDR, or maybe pre-XDR TB. All the others should be treated for 9 months and even longer, especially the XDR TB, which is very complicated. Bedaquiline and delamanid can be used at any age. Predominant cannot be used in children less than 14 years of age, and the BPAL and the BPAL-L regimens that you've heard of is only for children 14 years and older. It's not for the younger children. And most of these patients can actually now be managed as outpatients. We do not need to admit them to hospital for treatment. We usually stabilize them in hospital initially and then send them back to the clinics. But be sure that there's a reliable caregiver to give the medication so that there's observed therapy and that all of the drugs that is needed is available at primary healthcare level where these patients are managed. So here's the algorithm, and I included hopefully in the chat also the reference to the clinical management of rifampicin resistant tuberculosis, which was published already in September 2023. And here you can see that children under the age of 15 with non-severe disease, if it's MDR with fluoroquinolone susceptible and fluoroquinolone resistant, that is pre-XDR, these are the drugs that one can use, preferably with linezolid for the first 2 months. But remember that linezolid is a very toxic drug, and one should be able to do the necessary tests, specifically full count and differential white cell count to watch for toxicity, as well as monitor for peripheral neuropathy and vision in the children where they are treated. In severe disease, we treat them for at least 9 months. It can be longer, but not shorter than 9 months. And the same here, you can see also the treatment regimens. I'm not going into the detail now. You can read that up. And then again, the CNS, biliary TB, bone TB, pericardial TB, which is more severe forms, they are treated for a minimum of 12 months. And you can see the drugs that we use. And I've put on the side here a few red exclamation marks to remind me and you about the increase of bedaquiline and clofazimine resistance, which makes management of these patients very difficult. And remember that if the adult source case has MDR TB with bedaquiline resistance, with or without fluoroquinolone resistance, these patients need to be referred to either the provincial or the national clinical advisory committee or then to an expert who can help you with decision of the correct treatment regimen, because this will often include the injectable agent, preferably not amikacin, but meropenem together with augmentin, and those patients need to be admitted. Lastly, I'm just going to share with you that the drug-resistant TB treatment dosing tables used in the Western Cape currently. This is a summary basically in 2 pages of what is included in the South African RRTB guidelines, but it just makes it easier, and this will also be shared in the chat. And this is the first page, and it's divided up into Group A and Group B, because we first take drugs from Group A, then from Group B, and eventually, if we can't get a 5-drug regimen with these 2 groups, and we continue to Group C, where delamanid will be the most important drug. PAS can still be obtained, but it is difficult currently. Monopass is more available currently. But meropenem with the bedaquiline resistance is important. We've excluded ethambutol and PZA here because the doses should be known to you. But it can only be used in the case of confirmed susceptibility to either ethambutol or PZA. With that, I conclude and I hand over to Helena. Thank you very much.
Thank you very much, Prof. I think you've clarified exactly who we can do treatment shortening in and why we are adding ethambutol to the regimen. I just want to highlight that, as Karen has said, the guideline is not yet ratified. So this is the plan moving forward. But for now, you can add ethambutol already to those children that we should add ethambutol to, as Prof has indicated. And I saw there was also a question in the chat, should you now go and add ethambutol in children who you've started on treatment? And I think no, don't change the path of children that are already on treatment. While we are waiting for the guideline to be accepted, we will carry on with the previous guideline, and hopefully soon we'll be able to move over to this. And as Karen has mentioned, there's already treatment shortening accepted in the EML. So if you are going to consider treatment shortening, make sure that it's a patient that you're allowed to treatment shorten in, i.e. non-severe disease. And in those cases, one definitely would prefer to have the patient have been on ethambutol, because that is what the evidence is for. We are fast running out of time, and I wanted to do some cases with some polls to look at, you know, interesting discussion. But I think maybe what I'm going to do is I'm going to put our experts on the spot and ask them about cases. So I'm going to start with a 6-month-old girl. They have to take notes because we're going to flip through this very quickly. So she's got a 3-week history of coughing, and as per the norm, it's the middle of the RSV season, so everybody's coughing, and she's at some growth plateau. Her granny, who stays in the same house, was diagnosed with TB, but TPT was not offered. I think it's very important to remember that we must prevent TB. And she's examining normal. Her pulse is 110, respiratory rate is 37. She's 6 months old, if you can remember correctly, so kind of okay. No large neck nodes, not a wheezy chest. She's playful and interactive throughout the consultation. You don't have a chest x-ray, and though you did a TB NAT test, the result is not available, and you know that the mom and the baby have a negative HIV test. So I'm going to first ask maybe the risk of this child to have pulmonary TB and meningitis. Maybe, Karen, do you want to comment? Is this a high risk or a low risk patient for, you know, post-infection? Other people?
Thanks, Helena.
Yeah.
Yes, I mean, I think the age of this child is probably one of the highest, puts this child at high risk for TB meningitis. And although there's no clear symptoms from the history, I would definitely keep my radar on and ask more questions. We don't want to sit on this child for a long time.
Yeah. So I think it's important that we remember that the risk profile, you know, so part of the thing that we have to always consider is the risk profile. And this is a patient that have a high risk to move from infection to disease and a high risk of complicated disease, even though there's no symptoms. So I just want to highlight their timelines are important. And I want to also highlight that, you know, in the younger children, we may have meningitis as a very important thing. And when we're looking at children presenting with TB meningitis, often there were missed opportunities to prevent TB in many of those children. I just want to also highlight that we're seeing this a lot. This children that are just coughing, coughing, coughing. Everybody at home smokes, or they cooking inside with wood fire. So coughing can be a very annoying symptom. And we had a consultant years ago who would always say, this is no lastig. So that can soms lastig wees, and it can be quite annoying. But just remember, classically for TB, we have the unremitting cough, whereas with a post-viral wheezy chest, we have episodes of improvement and exacerbation. But we can also sometimes see in children post-RSV or influenza that they have a delayed recovery. And it can make coughing a very, I want to say, annoying symptom to decide what is its role for TB. So maybe, Jonetta, you can say, according to the treatment algorithm, should this child be started on treatment? Or should we use the scoring system to decide? Should we wait for the NAT? Should we insist on a chest x-ray? Or can we review this patient in 1 week's time You mentioned that's an option and that the algorithm never replaces sound clinical decision making. I want to just remind you, in case you forgot the treatment algorithm, Yoneta, this is where we are. What do you think? I mean, there can be a right or a wrong answer here, but what is most appropriate now?
So I think, thanks, Alina. I think we've got symptoms and signs suggestive of pulmonary TB because we've got a long-standing cough or a 3-week cough and weight plateauing. And then we've excluded danger signs, which is good, and hopefully excluded TBM along the way. And then our child is 6 months, so they're under the age of 2 years. So that would, you can see that would push them into the yellow bit. If we have X-ray available, it would be great to do it, but we don't want to delay the diagnosis by trying to get an X-ray. So as much as possible, we want to try and make the diagnosis and get them onto treatment appropriately and early enough. So if it is going to delay, I would say make the decision and try and get it if possible. And then okay, we've done the X-ray, we've done the testing, and then we go into that red box that you've nicely put up for me there. And so we don't have an X-ray, for example, the NAT is negative or unavailable. And we do have, you've mentioned that there is a household TB contact. And so in this case, we can strongly consider treating. This is a young child. They've got a chronic history of cough. You've got weight plateauing. You haven't really identified other reasons for this. And so if you're in a primary healthcare setting and you need to make a diagnosis and you don't want progression to disease, it would be fair to treat this child. But I think we have to ask a few important questions. I don't know if I'm skipping ahead to the main question I want to ask.
Yeah, so I mean, we insisted on a chest X-ray and we drove with it out to get the X-ray. So this is a tricky X-ray. I just want to remind you that there is a way to read an X-ray. One doesn't want to read a nonsense X-ray and come to the wrong conclusion. This is also highlighted in the guideline. But Prof. Scarf, what do you think? A severe disease or non-severe disease? Is it even TB?
Yeah, thank you. I mean, there's clearly very large lymph nodes, but what bothers me is the fact that these nodes are mainly paratracheal and not so much hilar nodes. And then one has to think of lymphadenopathy from other causes, specifically lymphoma. The airways look, you can't see them that clearly, but it seems like they are compressed, especially the trachea, so that will make it severe TB if this is tuberculosis. With the history of a TB contact in the household, I think it makes it easier, that most likely tuberculosis, but I think one should just remember that if the patient doesn't respond to treatment, that you must consider other diagnoses.
Yeah, and so in this case, the patient's NAT was negative. And, you know, as Prof said, there are these lymph nodes. So what are we going to treat this patient with? Yoneta, now, what do you think? You said you wanted to ask more questions. What question would you want to ask?
We want to know the TB contact exposure. We want to know the drug susceptibility of the exposure. I think if they were having DS TB, then it would be fair to give the first option because Prof has already explained to us why ethambutol is important in our setting. But definitely the answer would be, I need more data because we need to always look for the TB contact and the resistance profile.
Hopefully the NHLS is back on track soon. And this is actually one of our real patients' contacts resistance profile. I'm not going to ask you what you want to treat this child with, because I think this is where I would phone a friend. But I just wanted to highlight really that the most innocuous thing can turn into a problem if you go back and you find the resistance profile of the contact is very, very important. And also ask broadly about exposure. You know, sometimes the contact isn't in the house, but it's a neighbor that visits regularly. And Yoneta nicely highlighted the amount of exposure that we consider to be contact. Okay. Here's a child who's HIV uninfected, has a TB contact, failure to thrive, splenomegaly. Let's see. This is a classic miliary TB, I would think. So is this severe or non-severe? Easy answer. Even Karen knows. Karen, is it severe or non-severe? What do you think?
Definitely severe.
Okay, let's not joke. This is severe. But I want to ask a couple of other questions. You know, Karen, maybe you can say, or Prof, Do you think there are any additional special tests or other crucial things in this child?
Yeah, so I think following on the discussion that we had already, we have to remember that all children with malaria tuberculosis most likely has involvement of the brains. So doing, especially in the young children, lumbar puncture can be helpful. If you can't do it, you still have to treat them as tuberculosis meningitis with the 4 drugs for a minimum of 6 months. I think that's basically the important message. But one should also remember that if this patient was living with HIV, then one would remember that they can also develop complications, iris intracranial. So maybe one should consider postponing. And I'm talking now without knowing what the patient's HIV status is. But one should just consider postponing the ARVs for a month if they're not on ARVs already.
Yeah, I think that's right, Prof. And I also think just in a case like this, you know, it's fair to start the treatment, but this is also the kind of patients where if you send them home, be careful, make sure that you know who's going to give the treatment, and be aware if they deteriorate, that they might have central nervous system deterioration and, you know, meningitis. And it's important, you know, I think I always say to people, if you haven't missed TBM, it's because you're that guy that never comes to work. But TBM can be very, very subtle in the beginning. And as Jonetta said, just basically vomiting without diarrhea would be one of the most important symptoms to suspect TB in young children. And we often see these children are managed as diarrhea and vomiting, you know, and or, you know, influenza. And it's very important, vomiting without diarrhea. Really, really be careful, especially if there's a TB contact or chest x-ray that looks like miliary TB. Any other comments on this type of patient? Would you put this patient on a steroid, Prof? If you couldn't do a LP, you just do TB treatment?
Yeah, I think that is one of the difficult questions to answer. I think it's not wrong to put them on steroids, and the question is, should one put malaria TB patients on? And I don't think there's a definite answer. I think with the studies coming out now from adults, that even in adults with MRI scans, 80% of them have involvement of the brain. I do think it's not a bad option to do, as probably indicated.
One question's coming up in the Q&A, Prof, and it is about the shortage of ethionamide. Now, I mean, I think we can't really advise people, you know, from a Department of Health perspective. We should actually ask for a guidance on that. But if people are running out of ethionamide for children with confirmed meningitis, just as an interim measure, I do feel the Department of Health should guide on this, but would it be fair to add levofloxacin to those patients, or what would you suggest?
I think we don't have the outcome of studies yet, but levofloxacin does penetrate the blood-brain barrier quite well. It gives good CSF exposure, whereas ethambutol does not. So I think if I have to choose, I would definitely go for levofloxacin rather than ethambutol. So I think it's fair at this point to do that, but I think these patients need to be followed up very carefully.
Yeah, and I think the other important thing is that, as Prof has mentioned, the short course TBM studies using levofloxacin, we don't have the answer, whereas we know that with ethionamide, we can use short course in children who don't have HIV. I think let's skip this case and let's look at this one. So this is a child that you think have drug-susceptible TB. You've treated this child with 4 drugs. Can we consider treatment shortening? What do you think here, Netta? Would we consider treatment shortening in this patient with this chest radiograph?
It is a small picture, but it looks to me like there might be narrowing of the airways there unless I'm not seeing it well. We also want to ask all the other questions that Prof. Scarf has reminded us of. So if it's the first episode of TB, that there's no severe acute malnutrition, there's no asymmetric wheeze, and okay, you've got the HIV uninfected, so that's important. And if there are no other danger signs or were no other danger signs at baseline, and to make sure there was no extrapulmonary TB. But to me, it looks like there's airway narrowing.
Yeah, so I think also there's airway narrowing, and I just want to highlight that that's just one of the things to maybe also remember, that the child should improve. So if after 2 months, even if in the beginning you had non-severe TB on the chest radiograph, if the child isn't better, the default should rather be to treat for longer if you're uncertain, and the child should get better. If they're not better, then either you have the wrong diagnosis, or there's an adherence issue, or you actually misjudge the disease severity in the beginning. So remember, at 2 months, you can decide in the beginning it's not severe, but you do want to check later along whether the patient is actually improving. And yeah, just highlighting here that this patient has airway compression. And this is a nice one. So here we have a pleural effusion. So is this a severe pleural effusion or a non-severe pleural effusion? What do you think? Looks to me not like a ball under a carpet. What do you think, Prof?
Yeah, so I think in some of these cases, it's quite difficult to decide, because what one cannot see is whether there's underlying low involvement. If it is just the effusion, it's definitely simple. But what the rest of the pathology under that pleural effusion is difficult to see in this case. So I would be a little bit hesitant, but if in doubt, I would rather treat for 6 months. But otherwise, one can follow up and see how the patient responds. One can do a follow-up chest X-ray, and that would also help, because the pleural effusion should disappear quite quickly.
Great. And I think, again, just the importance of, you can have your idea that you can treatment shorten in the beginning, but the follow-up is really important. And in this case, if you're unsure, again, the default is 6 months. And what about a 9-year-old where we know the child has TB, but we don't have a chest X-ray? Can we treatment shorten in a 9-year-old? What do you think, Jonetta?
Not if there's not a chest X-ray available. Prof. Scarf mentioned that they have to be under the age of 8 if we have no chest X-ray available, given the type of disease they get as they get older.
Yeah. So I just want to highlight here again that older children tend to get adult type of disease, and that's why you must be really careful in older children. You need to get the chest X-ray, and not, even if they have few symptoms, you really should not treatment shorten if children do not have a chest X-ray and they are older than 8. And yeah, TB spine, can we treatment shorten TB spine with uncomplicated pulmonary TB? I just see head shaking. The answer is no. I think Prof also highlighted that very clearly. And lastly, yeah, a child with HIV and on antiretrovirals for 24 months, had a LDL viral load a long while ago, because we're only testing annually, and this child is confirmed TB. So I think first, it can be difficult to interpret chest radiographs, and many children with HIV have already had 1 episode of TB. So often they are excluded from treatment shortening simply by that fact, or from the fact that they have severe disease on the chest X-ray. But I think in this case, I think the one thing that I would want to add is that if you do want to check this viral load, right? Because we know that children with HIV remain at high risk of tuberculosis, regardless of antiretroviral therapy. So even if they are suppressed, they are at increased risk. But for us to decide about treatment shortening, we would want to know the viral load and know that this patient is doing well because one of the other reasons that they might be developing TB is that they've stopped taking the antiretroviral therapy and maybe having increased vulnerability again due to dropping CD4 count. I think this was the last case. I want to basically thank Jonetta, Prof. Scarf, Karen for being willing to discuss the cases and for joining the webinar. I think we answered most of the questions in the Q&A, Marty, either in the discussion or in the chat. But
Yes,
yeah, so up to you.
No, I think we have run out of time, and I think people are now getting a bit hangry, but you've answered so many questions through the presentations, and we really hope to share some of these resources on our website as well, and we'll use the pause group, and we'll use the South African HIV Society to share these resources with you. So I also just really want to thank everyone. It was a wonderful webinar. I said I was going to stop the speakers when they go over time, but I just couldn't, because it was just so informative that I really needed them to finish their presentation. So thank you for everyone that joined, and thank you so much, Helena. I don't know if any of the speakers have a little last word, maybe to just give us one word of wisdom that you are taking out of tonight's webinar, and one word that, or one sentence that you want to advise people out there that they need to change the way that they do the current TB regimens. Janita?
Thanks so much. I think from the diagnostics perspective, to have a really low threshold for diagnosing, for screening for TB and diagnosing, and to always ask for help if you're stuck. There's always help, one call away.
Great, Prof. Scarf?
Yeah, for me, it's difficult to say one word, but I think the most important is that to take a proper history and listen to the parents. It's so important because we neglect taking a history and going about asking where the patient comes from and what exactly happened to the patient. So history is very important.
Absolutely. Karen, your words of wisdom. Don't need to say
Thanks.
one word.
One word's going to be difficult, but Marty, thank you. I think for me, it's just that we are all scared to diagnose. Many people are scared to diagnose TB in children. And I think the take-up for me is that in the majority of kids, you don't have to be scared to diagnose TB, and it's not that difficult. Yes, there are some cases, like some of the cases we've talked about, that is difficult, but a lot of them are not difficult, and we can confidently diagnose them at all levels of care.
And then Helena, you've got the last wisdom for us.
No, thank you, Marty. I just want to say this is so exciting. I mean, in the last 2 years, firstly, we are bringing down the TPT duration to 3 months. This is absolutely amazing, making life so much easier for parents. And then I think if we can get this treatment shortening right, you know, and this ability to diagnose in the community-based setting and allowing all children to have good access to diagnosis based on sound principles that isn't over-reliant on, you know, necessarily a lot of technical expertise, and we can do this safely. And then on the other side, limiting the amount of therapy that children need if we can identify those children correctly. It is so exciting. I mean, nothing has happened in the TB space for so long, and finally, you know, we are moving forward. This is super exciting. And yeah, I really hope that, you know, those of you that think TB is boring will just know it's the most exciting thing that has happened to pediatrics in like a decade.
That's wonderful. And then I just want to thank the societies again, the South African HIV Society, SASPIT, and SAPA. And I really want to encourage people to join these societies. People really put in a lot of effort to bring the up-to-date latest things to you, and they really need your support, and they need you to be members. So I really want to encourage you to join them. them as a member. They've got some TB management and control online courses that you can do. And especially if you prepare for your HIV diploma, they've got wonderful resources. So please go and join them. And then I also just want to encourage all SAPA members. We've got a wonderful cardiac workshop coming up. For all our members, it's for free. If you're not a SAPA member, you can join for 500 Rand. And we did share the links in the chats. So please go and visit our Facebook and social media, get the links and register and stay up to date with what is the latest. With that, I want to really thank everyone for joining and just the panel. You guys are absolutely wonderful.